Hi, everyone. Thank you for coming to this year's Consumers First webinar, Priorities in Calendar Year 2027 OPPS and MPFS Proposed Rules. I'm Mike Persley, a Strategic Partnerships Campaign Manager here at Families USA, and I'll be your moderator today. Along with myself are some of my esteemed colleagues from our policy team. First, we have Aaron Plotke, our Associate Director of Healthcare Financing and Pricing, who will present on the Outpatient Prospective Payment System, or OPPS. And we have Senior Policy Analyst Alicia Camaliche, who will present on the Medicare Physician Fee Schedule, or MPFS. Next slide, please. Last month, the Trump administration proposed major changes to how Medicare pays for hospital care through OPPS and physician services through MPFS. Key provisions in these proposed rules, if finalized, would take important steps to rein in key payment distortions, including site of service payment differentials that drive hospital consolidation and unaffordable healthcare, as well as increase the accuracy of physician payment to ensure they reflect the true cost of delivering patient care. The MPFS proposed rule also includes critical opportunities to inform future policy changes towards increasing primary care payments, to bolster our healthcare workforce, and to reorient the economic incentives in healthcare payment to drive care that's accountable to affordability and healthcare quality and health outcomes. CMS is seeking feedback from the public on its proposals, which are due for OPPS by Monday, August 31st, and MPFS by Monday, September 14th. Families USA, along with the Consumers First Coalition Steering Committee, has analyzed CMS's proposals and is in the process of drafting 2 comment letters detailing our feedback. Today, we'll highlight areas, good and bad, that we've identified as particularly important for advocates like yourself to be aware of and comment on, that are critical for driving affordable, high quality, and equitable healthcare for all. Our hope is that by the end of the hour, we'll have convinced you of the importance of these issues and that you'll join our comments, once approved by the steering committee, by signing on in support so that we can send a collective message to the Trump administration that it needs to deliver affordable, high quality, and equitable healthcare for our nation's seniors. We'll be providing those comments to you in the coming days. So before we dig into those details, I do want to lay some general housekeeping rules for everyone. This webinar is being recorded and can be available to you upon request. Also, please put any questions that you have in the question and answer box, and we'll have time at the end to be able to answer as many of those as we can get to. So now I'm going to pass things along to Aaron to talk a little bit more about why it's so important for us to provide feedback to CMS on its proposals, and then he'll go into his OPPS presentation. So pass it along to you, Aaron.
Great. Thank you so much, Mike. It's wonderful to see everyone. Thank you all for joining today on this lovely August day. I hope everyone's having a relaxing month. So for those who don't know me, like Mike said, my name is Aaron Plotke. I'm the Associate Director here of Healthcare Financing and Pricing at Families USA. And so starting off, well, why sign on? So you all are seasoned advocates. So you already know that every proposed rule, request for information, or other request for comment is a critical opportunity for advocates to come together and share their perspectives to influence what are very significant policy changes. And this year, they are very significant. And in this case, key policies that impact how Medicare is paying for hospital and physician services. And so these are incredibly important, not only for our nation's seniors and all those who rely on Medicare in terms of their ability to access affordable, high quality care, but also for the millions of people who rely on Medicaid and commercial insurance too, since Medicare is a benchmark payer that influences how all other healthcare is paid across the system. We also know that industry stakeholders will be flooding the zone with their own letters and comments to get their industry perspectives in front of the administration and to influence these policy changes. So it's especially important that all of us, as advocates, including those in this coalition that represent consumers, clinicians, workers, employers, that we are coming together to present a unified front to serve as that counterweight to industry and industry interests, and ultimately to ensure that the policies and the programs that are governing our healthcare system truly are meeting the needs of the people it purports to serve. And we know, you all know, that people need relief. Affordability is top of mind for so many. And just yesterday, Family First released new polling that shows 94% of voters want lawmakers to take action to lower healthcare costs. So, as we already know, the public is with us. They are desperate for relief, making it all the more important that we come together to fight for consumers every opportunity we get. So, with that pitch, let's get into some of the specific policies that have been proposed in these rules. So just to start us off, I'm going to run through three major proposals that we've been tracking on in CMS's 2027 outpatient prospective payment system proposed rule, which again is making some major changes to how Medicare is paying for hospital care that are particularly important. You can go to the next slide. So to start us off, CMS is proposing to enact site-neutral payments for imaging services that will ensure consumers are paying the same price for the same service for services such as MRIs and X-rays in more outpatient care settings, including those delivered now by grandfathered or accepted hospital outpatient departments that were exempted from previous site-neutral policies. And so this is a very exciting proposal. This builds on previous actions this administration has taken to expand site-neutral payments, such as when they expanded site-neutral for drug administration services in last year's rulemaking. And so very supportive of this proposal. It's very exciting as it would continue to rein in a key driver of healthcare consolidation and high hospital prices. And as you all know, just to say it again, site of service payment differences where Medicare is paying more for the same set of services when delivered by a hospital or a hospital-owned clinic versus an independent doctor's office is a major incentive for hospitals to put patients into costlier care settings and to purchase independent doctor's office in order to generate higher Medicare reimbursements. And so what this means is higher hospital prices, more cost sharing and out-of-pocket costs for consumers, and higher premiums and system costs. Ultimately, we know that this distortion is a significant root cause of high US healthcare costs, and so we are very supportive of the administration taking yet another critical step to ensuring consumers and purchasers are paying the same price for the same service for a greater share of those services that we know can be safely delivered to patients regardless of whether it's delivered by a hospital-owned clinic or an independent doctor's office. And so while we are also continuing to make the case for lawmakers in Congress to take action and enact comprehensive site-neutral payments, we are also continuing to urge the administration, in addition to finalizing this proposal, but also using their authority to the greatest extent possible to expand site-neutral to additional services and sites of service. We can go to the next slide, please. So the second, not really a proposal, but more of a request for information is CMS is requesting additional information that they would consider to enhance the utility and the comparability of the hospital price transparency data that hospitals are required to disclose as part of the federal hospital price transparency rules. So while there's a number of specific and technical questions that the administration is asking for, our response here is that the most important step CMS could take to enhance the comparability and the usefulness of the hospital price transparency data is to require hospitals to post their negotiated rates in dollars and cents without exceptions. And as part of that, to reverse previously finalized policies that have allowed hospitals to post their negotiated rates as estimates, instead as estimates or ranges. So just for a little background, you may recall in last year's rulemaking, CMS finalized major exceptions to the price transparency rules that essentially is allowing hospitals, large hospital systems, to continue to hide their prices by posting algorithms and estimates instead of their actual negotiated rates in dollars and cents. And really, it's our perspective, it's that these types of policies that fundamentally undermine the stated intent of the hospital price transparency rule, making it that much harder for healthcare consumers, purchasers, researchers, and the public to know upfront the actual underlying cost of care and to understand where high and low value care is being delivered across the system, which is super important, especially so we can target additional policy solutions to drive the affordable high value care we all need and deserve. We also know this continued lack of transparency is especially problematic for healthcare purchasers, such as large and small employers and labor funds who are often negotiating the price of care directly. Because if they remain blind to the actual prices that hospitals are charging across the system, they can't negotiate a better deal for their workers, which ultimately means higher premiums and potentially less wages and take-home pay for their workers. And so here our argument is very simple. If hospitals can generate a bill based off the negotiated rates for each item and service, taking patients to collections oftentimes if they can't afford those high prices, they should be able to share those prices with us upfront with the actual purchasers of healthcare. And so as you see on this slide, in addition to pushing for negotiated rates, requiring hospitals to disclose their negotiated rates without exception, we're also recommending CMS take a number of steps to continue to strengthen its oversight and enforcement of the transparency rule as well. And so we know there are still too many hospitals that remain out of compliance with these rules. So in light of that, continuing to urge CMS to increase the financial penalties for noncompliance, as well as establish a process to publish and pair quality information with the published prices in hospital price transparency files. So we can not only have transparency on the affordability of hospital care being delivered, but also the quality and ultimately the overall value and cost effectiveness of the care being delivered. And lastly, we're also urging the administration to build on some hospital attestation requirements that were finalized last year and actually require senior hospital executives to sign their name on these hospital pricing files to confirm the accuracy and completeness of the data to, again, further increase hospital accountability to post their actual prices. You can go to the next slide. Okay, so the last policy here on the OPPS side is CMS is proposing to codify a new honest billing policy that requires off-campus hospital outpatient departments to use a unique and separate NPI number or a national provider identity number when billing Medicare, as required in the recently passed Consolidated Appropriations Act of 2026. So prior to the enactment of this honest billing policy, hospitals would often bill services furnished at their off-campus outpatient departments using a single hospital-level provider identifying number that is shared with their main campus, their large on-campus system. And so essentially what this did was created a level of opaqueness and lack of transparency in hospital billing, which prevented CMS, researchers, other policymakers, and payers from distinguishing in the billing when a service is performed at the hospital itself, like at the main campus, versus when it's delivered by a physician's office or a clinic that has been acquired by the hospital and billed as hospital outpatient care. And we know because Medicare pays so much more for the same service when delivered under the outpatient prospective payment system or under a hospital-owned entity than under the physician fee schedule, this shared NPI structure has allowed hospitals to convert acquired physician offices into higher paid hospital outpatient departments with no way to see that change or that conversion in the billing, in the healthcare billing data or in the claims data. And so ultimately, without this unique NPI requirement, payers, public and private payers alike, including CMS, had little ability to distinguish care being delivered at on-campus versus off-campus hospital outpatient departments, creating a loophole for hospitals to overbill payers and consumers. And so, therefore, we are very strongly supportive of CMS codifying these requirements that were originally passed by Congress to ensure we have true transparency in hospital billing, especially when the services are being delivered and billed by off-campus hospital outpatient departments. So with that, I'm going to turn to my colleague Alicia Camaliche to discuss some of the key policies that we're tracking on the Medicare physician fee schedule.
Thanks so much, Aaron. We can move to the next slide. So, hi everyone. Thank you again for joining us today. As Aaron said, my name is Alicia Camaliche. I'm a senior policy analyst here at Families USA, working on our Medicare payment and delivery reform portfolio. So this year's Medicare Physician Fee Schedule, CY 2027 proposed rule, made a lot of really technical changes to physician payment that have significant implications for patients and providers. And while there's a lot of provisions in the over 700-page rule, our upcoming comments focused on three main sections. First, changes to practice expense RVU calculations. Second, the redesigning primary care RFI. And third, the transition away from the merit-based incentive payment system, or MIPS, towards MIPS value pathways. And I'm going to get into all those details. While these are very technical components of physician payment, they have direct consequences for patients' ability to access high-quality, coordinated, comprehensive care, specifically primary care, as well as the financial sustainability of our healthcare system. So let's begin with the practice expense update. So CMS is proposing another key step in moving away from poor quality AMA survey data to inform Medicare physician payments, as building on that work from last year, to ensure that these Medicare physician payments are more accurate. They're doing so by phasing out the use of the indirect practice cost index, which is also known as the IPSI, in the calculation of practice expense RVUs. So, for some background, payments made under the physician fee schedule are calculated using relative value units, or RVUs, that estimate the resources or costs to delivering a specific service. One component of this calculation is the calculation of practice expenses, and specifically indirect practice expenses, which estimate the overhead costs of having a medical practice that need to be factored into service payments, like rent, utilities, or administrative staff. Under the current methodology, CMS calculates these indirect practice expenses using a formula that includes an adjustment using the IPSI. IPSI is informed by AMA physician practice surveys and is used to rescale and reallocate overhead office expenses across different medical specialties. Now, this is important for patients because the IPSI, as the final step in that practice expense RVU calculation, can have a significant impact on how providers are compensated for their indirect practice expenses, directly impacting access to patient care. CMS is ultimately proposing to remove the use of the IPSI to rescale those RVUs, subsequently having an impact on final physician payment rates. This change, again, like I said, builds on CMS's work from last year to continue to shift physician payment away from that over-reliance on outdated American Medical Association survey data, which we have long criticized. And we're choosing to support this change for a few reasons, most notably being that survey data used currently to inform the IPSI is not only outdated, but has also been criticized for having low response rates, substantial variation in reported costs across respondents, and limited transparency into survey methodology. Experts believe that these inaccuracies in survey data have embedded distortions in Medicare payment that have favored select specialties to the detriment of others like primary care and behavioral health historically. This has contributed to an underinvestment in some services and overpayment in others, and had largely impacted how patients are able to access quality care they need to be healthy. So because of this, we're asking CMS to finalize this rule and to continue to strengthen practice expense and RVU methodology broadly, specifically through the use of independent expert panels and real empirical evidence, such as that derived directly from practices. Of note also, CMS is proposing a stabilization adjustment that will prevent the practice expense RVU allocations for any code decreasing or increasing more than 5% each year. We're recommending CMS also finalize this provision to provide some financial stability to providers as this change in RVU calculation is phased in. And we can go to the next slide. So the next proposed rule also includes a lengthy request for information on how to correct the long-standing undervaluing of primary care services, how to pay for technology-enabled care in primary care, and how to best establish a prospective primary care payment. So this is a really critical moment to uplift the importance of investing in primary care for the betterment of patients, specifically how we can reform our Medicare payment system to better meet the delivery of primary care and ensure that patients have access to holistic, high-quality primary care. Within the RFI, CMS solicits feedback on a couple potential approaches to improving primary care service valuation that they're considering, and we ultimately chose to use this portion of the RFI as an opportunity to highlight the incompatibility between full fee-for-service payment and the delivery of holistic primary care. We explain that the fee-for-service payment model, by design, reimburses primary care providers based on the delivery of discrete, time-based services, rather than the longitudinal relationships and intensive care coordination that define comprehensive and effective primary care, and that patients want. We believe that even under a strengthened fee schedule, Medicare payment will continue to fail to support this form of care. And so ultimately, we support these smaller improvements to the accuracy of primary care payment in the physician fee schedule, but really urge CMS to go further and advance a prospective population-based payment for primary care providers, including through a hybrid or fully capitated payment system within the physician fee schedule infrastructure. So a hybrid primary care payment system that blends both prospective monthly payments that are flexible and allow providers to kind of adapt their care to the needs of patients and traditional fee-for-service billing is something CMS is already considering implementing. Within the RFI, CMS themselves explains that they're considering developing the existing Advanced Primary Care Management Codes, or APCM codes, which bundle management and communication services into a couple codes, into a prospective hybrid payment available in the Medicare Shared Savings Program. We strongly support the development of the hybrid primary care payment. This is something Families USA has long advocated for as a way to invest in flexible and comprehensive primary care. But we also push CMS to make such payment option broadly available, not only exclusively to providers in MSSP, inclusive of more services than just the APCM codes, and be designed to ultimately move and prepare providers to move into fully prospective population-based payment models that we believe ensure they're fully accountable for the quality and cost of care. And we can move to the next slide. So the last of these three main sections of our comment focus on CMS's formal proposal to transition away from the merit-based incentive payment system, or MIPS, to the updated MIPS value pathways by CY 2029. For those of you who may not be familiar, MIPS is one of the two participation tracks in the Quality Payment Program in which clinicians are evaluated across performance measures, and their Part B Medicare payments are adjusted based on that performance. The accountability to the Quality Payment Program and MIPS is a critical lever to holding providers accountable to the quality of care they're providing. However, it won't be a shock to many of us when I say that MIPS has failed to push the envelope and drive the delivery of higher quality, higher value care, and has ill-prepared providers to move into payment models that promise true accountability. We've really seen insignificant movement out of MIPS into AAPMs over the past few years, which was the ultimate and intended goal of the Quality Payment Program, moving more providers into those payment models that drive the delivery of high-value care. CMS introduced MVPs in performance year 2023 as a new streamlined reporting option under the Quality Payment Program. MVPs were designed to improve upon the complex and generalized MIPS reporting structure that has widely failed, like I said, to move providers into more advanced payment models, and has created a lot of burdensome requirements, and is ultimately just not really worked for providers or patients. While MVPs are important to an improvement to the many technical problems with the MIPS program, ultimately, in our letter, we feel MIPS does not go far enough in correcting some of the most notable problems with the design. MVPs do not go far enough in correcting the most notable problems with the design of MIPS, which include limited specialty-specific cost measures, delays in performance measures that make it difficult for physicians to adjust their behavior in response to performance scores, and ultimately little financial incentive to actually move into AAPMs that truly incentivize the delivery of that high-quality care. So because of this, we're urging CMS to develop fundamental reforms to MIPS that transform the program into one that adequately prepares and swiftly transitions providers into AAPMs that result in true accountability for patient care and result in better quality and care for patients. I'm going to close off by saying that there are several other important provisions we're not commenting on that I encourage you all to be aware of, including the implementation of the split conversion factor, changes to the G2211 code, restrictions to Medicare eligibility for immigrants passed in H.R. 1, and updates to the MSSP program. I'm happy to connect more on this rule, of course, if your organizations are looking to dive deeper into Medicare payment policy or are interested in signing our letter and would like some more background. For the sake of this call, I like to keep this a little bit brief, but of course, there's a ton of technicalities and details in here. And like Mike said, we're going to follow up with a copy of our comment letter for sign-on over the next few weeks or days ahead of the September 14th submission deadline. So please stay tuned.
All right, thanks, guys. That was great. So we just threw a ton of information at you all, and to a certain degree, like very technical information. So we wanted to open it up in case any of you guys have any questions, need some clarification, anything that you need. If you have questions, please feel free to put them in the question and answer box, and we'll do our best to get to them. Any questions? Going once, going twice. Yes, there will be a recording available. We will send it in a follow-up along with the slides tomorrow, uh, early tomorrow. We do have another question. Are there any concerns about the PFS changes negatively impacting independent clinicians? It's a Alicia question.
Yeah, happy to answer that. In the provisions that we're commenting on, again, some practices will see a reduction in payment from that practice expense calculation change. If, for example, the IPSI had really positively corrected or positively increased and adjusted indirect practice expense calculations, such providers will see a decrease. And that is why that kind of 5% adjustment that prevents those practice expense RVUs from increasing or decreasing more than 5% each year is important. It will help phase in any of those reductions or increases to provider payment. But what I will note is for the provisions that we talked about, especially that practice adjustment change, the effort here is not to negatively impact independent providers or any providers. The intent here is to improve the accuracy of physician payment by ensuring that that calculation of payment is as accurate as possible. I'll also say that CMS had made changes last year to practice expense calculations, including an efficiency adjustment and other changes that in some cases did positively benefit independent providers as well as primary care providers. So there is an intent to both really level out payments and make sure they're accurate. There are some other provisions in the rule that we did not comment on that may have more impacts on provider payment, including that of independent providers. And I'm happy to connect on those specifics at another point in time, a later point.
Thanks, Lisa. I do want to point out there's a few people that have their hands raised to ask live questions. We are not answering live questions today, so if you can, put your questions in the chat and we'll do our best to get to them. There's another question about the sign-ons from Adam. We are in the final stages on both letters of getting kind of the final details ready, so they should be available as soon as we get those finalized, but they're not available now. Any other questions? This is an Aaron question. Do we know if the site neutral changes from last year actually resulted in savings to physician administered drug payments?
Yeah, that's a great question. So I think at this point, I have not seen any updated actual data on the savings related to drug administration, but absolutely we expect as the year continues that where drug administration and the site neutral pieces for drug administration were started to become into effect in the beginning of 2026. And so as the Medicare billing data gets updated and we get access to that data, and researchers get their hands on it, I think we definitely expect some substantial savings, both to the Medicare program and also to Medicare beneficiaries in the form of reduced cost sharing and things of that nature.
Perfect.
That's a great question.
One more Aaron question. Do you see any unintended consequences of reduced access as a result of site neutral payments?
Yeah, great question. So I think, fundamentally, I think our perspective is that it's really the site of service payment differentials and the incentive for these larger hospital systems to buy up independent practices is really the major risk to access to care. Because we often see that when hospitals and these large systems are buying up smaller practices or smaller clinics, they're often or even smaller hospitals are often closing down different service lines like OBGYN services and other, I think, from their perspective, less profitable service lines. And so I think from our perspective, really like to address this key payment distortion is an important way to actually safeguard access and improve access while also absolutely recognizing that certain providers, especially rural independent hospitals, other safety net hospitals of that nature, are vulnerable to having unstable finances and things of that nature, especially in light of HR1 implementation and other pieces. So to absolutely recognize that. And I think there's definitely some targeted ways in which you can ensure that as we implement a site neutral policy and transition to a site neutral policy, that there can be accommodation for those safety net or independent providers as well. That's a great question.
Great. And Aaron, I have another one, popular guy today. So, and this is really gets to like why we should be commenting on these things. So it's based on Families USA's experience in submitting comments for proposed rulemaking for this administration. To what extent are you finding that the administration is actually following protocol and responding to public comments prior to issuing their final rules?
Sure. So I think there's obviously that it varies the extent to which the administration is actually going to like change a proposed policy when they finalize it based on comments. I think we do find that the administration does grapple with the comments they receive to varying degrees. But I think all to say that it's still very, very important that we as a community are weighing in and putting our perspective there, even if in some cases we're not going to get everything we want, but at least it sets a standard and it puts kind of a position in the ground of where we stand on these issues, and also does create a legal obligation through the Administrative Procedures Act for them to at least respond to a degree. Um, and so I think it's overall very important that we continue to do that. And I think, especially on these policies around affordability when it comes to hospital prices and physician payment and primary care, I do think there is some appetite for this in this administration to take on these issues. And, not going to agree on everything, of course, as I'm sure many share, speaking from the Families USA perspective, but I think they definitely want to hear from us. They definitely want to hear why we need to pay primary care more, why we need to rein in high hospital prices, why we need to, deliver affordability in these ways. And so I think we should keep up the drumbeat on that.
Yeah, and I'll even quickly add there on the primary care piece. Last year in our comments, we wrote about the importance of investing in primary care and have repeatedly emphasized the importance of the development of a hybrid or fully prospective payment system in the fee schedule. And we are seeing an RFI directly in response to that feedback. So there are moments, I think, especially in the primary care space and in the physician payment space, that CMS is looking to improve valuation and they do want to increase investments in primary care. So there are certainly ins that we have found them to be pretty responsive to, and there's a perfect example in this year's rule.
Great. And we have another question that could go to, I think, any of you. It sounds like the shifts are advantageous to Medicare enrollees, like making evidence-based pricing calculations, increasing availability for primary care, improving quality standards. But will these proposals actually reduce Medicare spending?
Yeah, I can take a first crack at this, and Aaron, feel free to jump in if you have more thoughts. On the physician fee schedule side, a lot of the changes made in the fee schedule are budget neutral, which means decreases for some payments will result in increases in adjustment and positive adjustments to others, as a statutory mandate to how CMS is approaching proposed rulemaking. And we directly see this, for example, in the IPSI removal. We will see some services have that reduction in payment, and we'll see others have a bump in payment as a result. But I will say on the primary care side, there is a return on investment investing in primary care that results in long-term savings. We do know that improved access to high-quality primary care improves long-term health outcomes and reduces long-term health expenditures. So I think there are ways in which the changes outlined are beneficial to the financial sustainability of the Medicare program, but I will clarify that the changes, including the IPSI change, and many of the changes you'll see in the Medicare physician fee schedule are budget neutral and won't necessarily specifically result in a significant drop in Medicare expenditures.
Perfect. And Alicia, we have one more for you. I know CMS is interested in rethinking the AMA's role in RVUs and the RUC as a whole. Do you think they will continue to more aggressively pursue this in the next two PFS rules?
Yeah, I think, we got a really strong signal from CMS last year that they recognize that the AMA survey data so strongly dictating physician payment rates is not aligned with how evidence-based payments should be set. And, we saw significant changes last year that reduced the influence of AMA survey data on the rate setting process and like Medicare physician payment rates largely. I think that they're sticking to that and they're continuing to not only explore and adapt to and adjust Medicare payment to be less impacted by those AMA surveys and to instead seek out more empirical evidence sources. And we'd love to, I think this is something that is a great opportunity for folks to comment on and signal to CMS that this is a good change, that we want payment rates that are evidence-based. We want payment rates that are empirically verified. We want to make sure that we are adequately compensating our providers and also in some cases not overcompensating others to the detriment of things like primary care and behavioral health.
Great. And is there any more questions? I think we've gotten to most of them. Got 20 more minutes we can take. Okay, going once, going twice. Ooh, last second.
I see another question on AI in Medicare and making sure that payments are not dictated by AI models. So, Julie, in the primary care RFI, there's a lot of question on compensating providers for technology-enabled care, which naturally I think does include providers who are using a variety of technology, potentially including AI. We didn't talk specifically about payments that are dictated by AI models. Currently, we have a robust payment setting process, but I'm happy to chat with you more directly on the concerns around AI and dictating primary care payments, but also how AI is being used in healthcare and primary care. We're actually working on talking a little bit more about AI in healthcare in the future. So happy to connect one-on-one.
Great. One last question, and this is a good question actually. I was wondering if CMS doing site neutral in rules. Well, just got deleted.
I think I saw the question, Mike.
Go
I think
ahead.
that's a good question. Yeah, like the extent to which the administration is using its regulatory authority to extend site neutral payments, does that take wind out of the sails on legislative efforts? And I would say it's definitely a both and. I think we want to keep encouraging the administration to do what it can to expand site neutral payments to additional services, traditional sites of service. But I think it's also incumbent upon us as a community to also focus on the legislative effort to get comprehensive site neutral payments enshrined in law, so it can be, a sustainable long-term solution in general. So I think it's definitely both and. I think there's different, I think, in our political team, government relations team might have other thoughts, so definitely weigh in. But I think it can both, the administration in taking these steps can also, I think, provide Congress with the push they need to take action, because they're saying the administration is bringing more attention to this issue, and we need Congress to step in and also take action and build on what the administration's been doing. And so I think it could be a symbiotic relationship and a helpful relationship.
Perfect. And I think we're going to wind down the webinar. So if you can go to the next slide. Well, first, thanks everybody for coming. These were great questions. We hope that we presented information to you that shows why this is such an important like topic for us to be commenting on these proposals. Next steps. Watch your emails because, like I said, we're in the process of finalizing both of our letters, and they'll both be available for sign on. So we will send those to you as soon as we have them, and hope that you will sign on to them and really build our collective voice. So for OPPS, the deadline is Monday, August 31st. And for MPFS, you got a couple more weeks. It's Monday, September 14th. We will send tomorrow a follow-up slide that will include the slides from today's webinar, as well as a recording and contact information. So if you have any questions about OPPS, you will have Aaron's email available to you. If you have questions about MPFS, then Alicia's email will also be available to you. And then if you need any kind of technical assistance, just in terms of resources, feel free to email me, and we're happy to help you guys in any way that you can. So keep your eyes out on emails, and we will call it a wrap. So have a good day.
Thank you everyone for coming.
Thanks,
Appreciate it.
everyone.